Can we start the panel discussion, Praveen? Shall we take the question and answer session? Either from the slides or from the case scenarios, whatever it may be. Any questions on insulin are welcome, please. I once again request my participants to type your questions or queries, whatever you have on insulin, and you put it in the chat box so that now it is time to take up the question and answer session. Yeah, let us go ahead. Praveen, if there are questions, you can read it out. Or are there any questions? Yeah, please. Yeah, can you be a little bit loud, Praveen, because not audible in the sense. Yeah. Yeah. No problem. Yeah, carry on, Praveen. Yeah, Humayun. Yes. Hi, Dr. Humayun. Okay. What about first question, Praveen? Question number 1, we have what is the first question? Pardon? Acha. So, the question is there any difference in managing the hyperglycemia with regards to the medical wards and the surgical wards? Absolutely nothing. Yeah, it remains same. You need to tackle the inpatient. The only thing is whether the patient is in the non-critical setting or in the critical setting, that is in the ICU. Whether it's a medical case or a surgical case, it doesn't make any difference in tackling this particular hyperglycemia. Maybe the reason is acute infections in medical wards like COVID and dengue, what you said, and maybe in the surgical wards it's a case of diabetic foot or cellulitis or some sepsis. Something else will be in there. Only thing is the other treatment varies with regards to the case concerned, but the treatment for hyperglycemia remains same. That is, the best is to switch off all the oral drugs and stop all the oral drugs and start the Basal Bolus regimen of insulin therapy. Yeah.
Sir, ask the question once.
Yeah, please. Yeah, question please. IV insulin. See,
Resound also, sir. Question mala
the IV insulin and the subcutaneous insulin I have already discussed. In the critical care setting, we always go for an IV insulin setup, and where the patient is in the non-critical setup in the hospital setting, we go for subcutaneous insulin. There is no cutoff actually. Only thing is it remains on the skills of the clinician whether he is able to maintain the IV insulin drip or not. That is the only point to be considered, is whether the clinician is able to maintain that particular insulin drip or not. Nothing is like I have said it very clearly. My message is very loud and clear. The patient is in the critical setting, in the ICU setting, so the patient has to be put on the IV insulin, and if the clinician is trained in that particular this thing, and if the patient is not in the critical setting, it is in the patient is in the non-critical setting in the hospital scenario, you can just continue with this particular the subcutaneous insulin, There is no cutoff point for that and all. Everything works out to be well. Only thing is the IV insulin goes very fast and it drastically reduces the blood sugars, and you have to be very cautious with the IV insulin, because you need to have a three-way cannula first of all, and the moment the blood sugars reach the level of 250 milligrams per deciliter, you should simultaneously start the dextrose also to prevent the deadly hypoglycemia because of the IV insulin. So with subcutaneous insulin, you can go slow, you can titrate, you can intensify, you can optimize and all, you can do that, and you can bring back the blood sugars to the normalcy. Next question, please. Yeah, can you just repeat the question, please? Along with basal bolus regime, the intermediate like NPH. Yeah, no way. No way. See, the basal bolus is taking care of the. It is going to take care of the both the aspects, the basal part and the bolus part. And why do you want this NPH? The NPH is not required actually in whatever be the setting. Let it be COVID setting or something else. What else? What all you require is something like if at all you don't want to go for this, at the time of discharge you can just put the patient, the COVID patient, on only this basal insulin when the patient is on steroids actually. You should never combine basal bolus regime with this NPH, that is intermediate acting, should never be combined with the basal bolus regime. If the patient cannot afford to go for this basal bolus regime, you can go for the NPH, but with the regular insulin in non-affordable patients. Like you can use it twice a day, the NPH, because it is not going to act beyond 14-15 hours. So you can combine the regular insulin, that is what is called, as a speaker I am not supposed to take out the brand names, but for the sake of the participants I have to say that Actrapid 3 times a day with Insulatard, most of the times it is given twice a day. So the patient has to take 5 pokes. This is also the one of the cheapest basal bolus regimen. Yeah, please. Yeah, you're most welcome. Yeah. Grade 3 at the time of discharge, because the critical case which was presented by madam, the first when the patient came to the hospital, the patient was in stage 4 DKD, so we totally stopped. And after that they said at the time of discharge she was put on 1.5 gram of metformin. But as such, to tell you very honestly, it is a blunder what they have done. See, she is in stage 4 at the time of admission. At the time of discharge, the patient was in stage 3B DKD. So according to the latest US FDA guidelines for the use of metformin in 2019, so you can use metformin until an EGFR of around or more than 30 ml per minute if the patient is on metformin earlier. And the second category is the drug naive patient, that is the patient who is not on in metformin. The cutoff point for initiation of metformin is around or more than 45 ml per minute. So this case I would like to contradict with the post discharge treatment. I wouldn't start either antihypertensive or glimepiride or metformin also, keeping her low EGFR. She is still in the recovery stage, so she is taking the steroids, and as per the recovery study which is done in the UK by the Oxford researchers, the dose of dexamethasone in the critically ill setting, the ICU, it is only 6 milligram per day for 7 to 10 days. You don't need to taper the dose. For 7 to 10 days, you don't need to come down to start with 6 and come down to 4 and come down to 2 and all is not required. This is not evidence based. And second thing is, when the patient is on steroid, I wouldn't like to start the orals, especially a drug like metformin, which may spoil the kidneys, already spoiled kidneys. So I would like to increase the dose of degludec and continue for some time and see the fasting blood glucose. And if at all she requires, I would like to shift from degludec to insulin degludec aspart once or twice. That is the co-formulation. It's a wonderful question raised by the participant. I was just waiting for this question. It's a blunder that they have put the patient on 1.5 gram per day. If at all you are so fond of metformin, you can start with 500 milligram SR at the bedtime, slowly monitoring the serum creatinine and calculating the estimated glomerular filtration rate. You can go for this particular increasing the metformin to 1000, and after that you can slowly, if the patient recovers and if the patient EGFR increases and it is beyond 45, you can go for 1.5, and later on you can go for even 2 grams also if the total recovery is there and the patient stops the steroid and the glycemic the triad is met, that is the fasting plasma glucose and the post lunch plasma glucose and the HbA1c are absolutely fine with a normal estimated glomerular filtration rate. You can just go back to the 2 gram metformin. That's a wonderful question. I was just waiting for that, Praveen. Yeah, next question please. Oh, wonderful question. I was waiting for this question actually. See, there are two options, Praveen. Yeah, to be honest with you, either you should reduce the dose of sitagliptin 100 to 50 milligram or even to 25 milligram in that particular case, the time of discharge, or the best thing is the real gliptin and the real renal gliptin is linagliptin, the only gliptin that can be used in any stage of the DKD, irrespective of the EGFR, and any even ESRD or end stage kidney disease, it can be used. I would love to shift from the sitagliptin to linagliptin, keeping the renal benefits and the cardiovascular benefits of this. And even the patient gets into a stage of dialysis that can be continued along with insulin. Even the transplant also that can be continued along with insulin. Even the post-transplant, there is a condition called post-transplant new onset of type 2 diabetes, wherein this is the drug of choice. Linagliptin is the real renal gliptin, where you can switch over. If you want to continue the sitagliptin, you have to come down to as low as 25 milligram. You cannot stay with 100 milligram at any cost. This is a wonderful question. These two questions, I was just waiting for that, and that is the reason why I asked Madam not to disclose anything, not to discuss anything. That's it. Thank you so much. Next question, please. Yeah, audience are very good today. Yeah, very shrewd. They have keenly followed the entire message. Yes. So is it related to the second case? Okay, no problem. I'll answer. See, first of all, we need to consider one thing: the COVID case. See, we differentiate the cases as my case was dengue case, ma'am's case was COVID case. The COVID case, the HbA1c was 10.2, terribly out of control, and blood sugars were not at all to the target. So, irrespective of this particular situation, I would love to continue all the medicines along with this degludec for at least some months or years. I don't want to discontinue the degludec. I just want to pass on the benefit of the best basal insulin on the earth, insulin degludec, at least 10 to 12 units a day at 10 p.m. I think that will change the entire scenario. Like the glycemic triad will be met very, very successfully. So, in case everything is well and the blood sugars are maintained, if you want to, the affordability becomes a problem, you can stop this insulin degludec after a couple of weeks and with no steroids. As long as steroids are there, the patient has to be on insulin degludec. That is mandatory. That is as per the latest COVID guidelines also. Even the 2022 guidelines also say that the patient is on steroids. In the earlier also it was there. Even 2021 also they said the guidelines were same that the patient is on steroids for COVID. It should be the basal insulin should be the drug of choice. If the patient happens to be like suffering from diabetes. So in that case also the patient is otherwise okay. If the patient is not on steroids, after a couple of weeks the affordability is a problem. You can cut off the basal insulin, the degludec, and you can switch over to the old regimen along with at least the addition of the SGLT2 like either the empagliflozin or dapagliflozin must be initiated. So what is required is at the end of the day, we need a normal fasting plasma glucose which is somewhere in between 80 milligrams to 130 milligram per deciliter. At the end of the day, we want the 2 hour post glucose, either the 2 hour post breakfast, 2 hour post lunch, 2 hour post dinner, or the 2 hour not 2 hour, the any time of the day except fasting. That is the definition of casual plasma glucose is to the target, that is around or less than 180. You can you can, as long as the HbA1c is around or less than 7 or 6.5 to 7, you can add this particular SGLT2 inhibitor. Already the patient is on metformin, the renal condition improves, she can continue metformin, she can continue sitagliptin or linagliptin, she can continue glimepiride. You can only titrate the dose, the up titration is required. And I think it's high time the patient requires a basal insulin, at least because as per the evidence based medicine, what it says is when the patient is on 3 oral agents and still not to the target, it is high time you have to go for insulin. As per the recommendations of the American Diabetes Association, as per the recommendations of the American College of Endocrinology and the AA's, that is American Association for the Clinical Endocrinologists, the funda is same. The A1C is around 9 or more. The 3 drugs, the insulin should be initiated. In this case, I think it's better the patient is on insulin along with the drugs. You can add the dapagliflozin 10 milligram. Now the generic versions are very much available, and instead of sitagliptin, you can even go for the vildagliptin also. It is off patented. The 50 milligram BD hardly costs 10 rupees, 5 rupees each. Even the majority of the companies have come out with 100 milligram SROD, so that is 10 rupees. So the patient is not affordable. You can go for an economical prescription like glimepiride with metformin and the vildagliptin and the dapagliflozin 10 milligram. Along with this, the basal insulin, I think that is the treatment of regime. That's what I do in my clinic. So methodically you should do, and you should always you should abide by the guidelines and recommendations also. You cannot violate or deviate from the recommendations. Okay, it's good that questions are over. Any questions from Novenadis? From your side, Praveen? Yeah. Yes, bro. Yeah. Yeah, you are absolutely right, Praveen. See, the once a week titration doesn't hold good in the hospital setting. Hospital setting, it should always be every day. You should monitor every day. You should check the fasting. You should increase or decrease this the basal insulin degludec. You are absolutely right. That is evidence based medicine. So now see, if the patient is not hospitalized, he is in the OPD setting, and you can titrate it on weekly basis. That's not a problem. But as far as the hospitalized patient, whether critically ill or the non-critically ill, the dictum is that everyday fasting must be taken, and this particular the dose of insulin degludec either must be up titrated or down titrated, Praveen. Yeah. Degludec? Yeah, I'll answer. No, degludec comes in only one this thing, that is nothing. Degludec is degludec, that's it. That is 100 only. Insulin glargine comes in 2 strengths, that is U100 and U300. As far as degludec is concerned, there is no dispute, it is only one, that is degludec, that's all. Yeah. Oh, wonderful question. I was waiting for that. So the Novo Nordisk people have the wonderful co-formulation called Rhizodec with this particular insulin degludec along with insulin aspart, that is the prandial insulin, and this is the basal insulin. So now that this becomes a co-formulation, so it's a wonderful combination of the basal insulin degludec and the best the best prandial insulin, insulin aspart. That is called the basal plus combination that can be used. How to initiate this particular insulin is, you have to initiate this particular insulin rhizodec or insulin degludec aspart, the basal plus combination with the largest meal of the day, and you should talk to the patient which is the largest meal of the day. So according to him, so if the lunch happens to be the largest meal, you take that particular combination, insulin degludec and the insulin aspart, the basal plus combination with lunch. And if the patient has the dinner, he says the largest meal, you go with the dinner. And if the patient breakfast is heavy breakfast like a king, you can ask the patient to take this just 5 minutes prior to this, the basal plus combination. And off late, not in India, the degludec U200 has come, but not in India. Okay. Any more questions? No. Rhizodec is available in only one combination, only one strength. One strength. That is 30-70. That's all. 30-70. So still no 50-50 is available. Rhizodec is only available as Rhizodec. That's all. Tresiba is available. Insulin degludec is available as Tresiba only in India. Nothing else other than that. And insulin aspart is available in two forms. From the same basket of Novo Nordisk, they have got insulin aspart as this particular Novorapid. The brand name is Novorapid, and it is available from 2016. So that is called the fast acting insulin aspart. FIASP is the brand name. So catchy. Fast acting insulin aspart. FIASP is available, as well as both are efficacious. Both the normal aspart as well as the fast acting aspart, both are equally potent. Both have equally they decrease the blood sugar levels, the post meal equally, and the A1C reductions are also at par with one another. That there is no much difference at all. But the latest one is the fast acting insulin. That was launched in 2016 EASD, which was held at Lisbon, Portugal, where I was there. Yeah. Yeah, please. Patients with COVID with early cirrhosis. Yeah. Treatment of option in early cirrhosis doesn't make any much difference. Only thing is you need to take out all the hepatotoxic drugs. If at all you want to, the best thing is, I would love to go for this insulin degludec as a basal insulin. I would love to place that, and along with that the treatment consists of the pioglitazone and the metformin and the vitamin E 400 milligram given BD, and the fibrates and the statins and the saroglitazar, and there are so many modalities. Even the DPP4 inhibitors, they play a vital role, and out of that you can take out only this particular the linagliptin, or the best is linagliptin. Better to avoid all the other gliptins, and even the empagliflozin, the SGLT2 inhibitors. Either you can go for empagliflozin or even dapagliflozin also. Dapagliflozin in the form of in the strength of 10 milligram, and if it is Zampa, it is 25 milligram. You can continue with what I said. The pioglitazone should be in the maximal dose, like if the patient is not associated with cirrhosis, not cirrhosis, the ascites. The patient has no jaundice, no ascites, you can go for 30 to 45 milligram. But if the patient has got ascites and he has got developed jaundice and no other oral medications, only you have to stay with the insulin, degludec and aspat, and BID must be the regime. That's all. If the patient is affordable, the Rhizodec is the option. The patient is a little bit non-affordable, the Novamix 30 is the option. The patient is not at all able to afford to go for all these things. I think the best is the human biphasic premixed insulin, human mixed 3070 will be the solution for this. And no OADs, please. The patient has got cirrhosis with ascites and jaundice. No oral drug should be given other than this. Anything that is given by either the medical gastroenterologist or the surgical gastroenterologist. But as our part, as clinician treating diabetes, either the primary care physician or the diabetologist or the physician or the endocrinologist, we are supposed to use only insulin in that particular case. Can I add something to this? Yeah. Actually, what happens is the NAFLD, that is the non-alcoholic fatty liver disease, is so common in the general population and even in the patients suffering from type 2 diabetes. We are very commonly seeing this entity. This is called the hepatogenous diabetes, that is the two organs involved, that is the two diseases, two entities are involved, the diabetes involving the liver involving the diabetes. So the patient can be picked up in early stage. If you just write an ESG, ultrasonogram abdomen, you get the finding like the fatty liver, and the radiologist will grade it, grade 1, grade 2, grade 3. And if you refer the patient to this, the medical gastroenterologist who has got this fibro scan, if you can get it done, so you can stage whether it is NAFLD, that is, or the NASH, that is non-alcoholic steatohepatitis. And at that particular case, if you start the lifestyle modification and the therapeutic lifestyle changes, that is diet, exercise, reduction in the weight, cessation of alcohol, cessation of smoking, along with a large dose of pioglitazone, that is 30 to 45 milligram of pioglitazone, and 2 grams of metformin, and vitamin E started in the dose, vitamin E Evian 400 once in the morning and one in the night, 1 BD 400. And along with the statin, along with the DPP4 inhibitor, I said the linagliptin, and the Indian teneligliptin can be used theoretically, but I don't like to use that because it has got some cardiovascular side effects like the increased QTC interval, which may lead to sudden cardiac death and something else. So, and the addition of empagliflozin or dapagliflozin is going to minimize the scarring of the liver. It prevents the fibrotic stage, that is the early cirrhosis can be prevented if you start all these measures along with the lifestyle modification, the therapeutic lifestyle changes, and the drugs which I have mentioned, even the saroglitazar also. If you can use them very judiciously and very cautiously, and keep monitoring the liver enzymes and all, you can prevent the scarring, that is you can prevent the patient getting onto the cirrhosis. And once the patient reaches the stage of cirrhosis, I think nothing is going to be fruitful. Liver scarring is there. Once it is, you find a scar in the lung, or once you find scarring in the liver, the fibrotic process will be always progressive, and that results in the next stage is only hepatocellular carcinoma and death. That's all. Yeah, next question, please. Absolutely not. Rhizodec is not a drug of choice in pregnancy. Please, pregnancy. I would like to tell you, you can use the first. The option is the NPH is the drug of choice, and followed by the that is insulatard becomes the first drug of choice, and second is you can go for regular that is the human actrabit can be used, and you can go for even the biphasic human mixed insulins like the this one the human mixed ad, and you want to go for analogs. Insulin detimer is the option. Insulin detimer can be given. That is the best drug of choice for the patients with pregnancy. I cannot call the patients because pregnancy is a physiological condition, and out of which there are two conditions. Either the pre-gestational diabetes mellitus, that is either the patient is already suffering from or diagnosed type 1 diabetes complicating to pregnancy, and type 2 diabetes complicating to pregnancy, that is pre-gestational diabetes mellitus, and per se the definition of GDM is any degree of glucose intolerance during pregnancy is defined as gestational diabetes mellitus, and if you pick it up early in the first antenatal visit itself, you can just try with the lifestyle modification and the therapeutic lifestyle changes, and with diet and exercise it can be controlled with minimal reduction in the weight and cessation of smoking. Nowadays even the I'm sorry to say that even the Indian ladies have started smoking. Already they have been taking alcohol and cigarettes for a very long time. Even when we were medical students, we used to see in the girls hostel they used to take everything, alcohol and all. It has become like the social drinking or something else. So they have to abstain themselves from this alcohol and the smoking, and then we can just manage them with diet and exercise. If at all they need, we can just go for this. The basal insulin Levemir will be the best. If the patient is not able to afford to go for that, we can go for this NPH also. Yes. Okay. Yeah. Yeah, thank you so much, Praveen, and thank you, Novanadis, for giving us the opportunity to be the speakers of this evening, and a wonderful real case scenarios we have discussed, and my sincere thanks to all my participants and professional colleagues who have participated so patiently, and for your patient listening and your wonderful response in terms of pouring down the questions. Thank you so much, and we take leave of you. Thank you so much.